Hello.
Hello there. I am so glad to finally be doing this with you.
I know, me too.
It's been a long time. I think I had to reschedule once because of work, I'm sure. But
Oh, that's all right. Things come up all the time, so I get it.
it happens. Yeah.
Yeah, especially in MFM.
It does for sure. Okay, well, I'll do an introduction here. This is Liz Sheehan, and you are in Pittsburgh, which is where I did my residency.
Oh, very cool.
I did at
residency
at Allegheny General. Yeah.
Oh, very nice.
They fused with another program, so I don't think they have an OBGYN residency anymore, but that's where I trained.
Okay,
but
cool.
you are at McGee Women's Hospital, and you are a genetic counselor there.
Mm-hmm.
And we are going to talk about something that is genetics related, but not necessarily with genetic counseling. But do you remember why we even started talking on Instagram? I remember.
Vaguely.
Because
I think I first started following you because someone in medicine finally started calling BS on MTHFR. So that was the first reason. But other than this topic, I can't quite remember how we got
I remember because I started, I have been making a conscious effort to use inclusive language in my videos. And I'm not 100% perfect, but I'm definitely trying. And I was getting a bunch of heat. From those who didn't agree with it.
Right.
And you messaged me and you told me that you actually made an effort to change within your department. What is it that you did?
So I had a couple of patients and we were just noticing some just differences in equitable care if they were going to be identifying as trans, particularly if they were trans men and were pregnant. In Pennsylvania, you can legally change your sex listed on all your government identifying documents, and that does not require essentially what's called bottom surgery or complete removal of your female reproductive organs. And so I've had a couple of trans patients that have been pregnant and just experiencing just everything from slight comments from other people in the department to we literally could not do ultrasounds for them because we could not pull them up in our OB ultrasound system. And so just kind of putting those to the forefront of upper management of saying, hey, this isn't okay. We need to be more inclusive to our patients. And then doing trainings in our department, a couple other departments on language that's far more inclusive for our gender and sexual minority patients, and therefore inclusive to everyone, and how to implement that into our counseling, into intake on the phones for our schedulers, and just how to implement those into daily life, because I think they're really helpful for daily life as well.
Yeah, I agree. And you know, for me personally, this is started mainly on my social media, my efforts to do this. And it takes an active effort. But what I've found is the more I work at it, the easier it is.
Oh, yeah.
And I actually just finished a paper and submitted using gender neutral language. And it's the first paper I've ever written. We haven't gotten any reviews back yet, but we'll see if they pick up on it. So I'm curious to see. But you know, it was not as hard as you would think.
No, it's not.
And it's really not. So, and I also want to make the point that by using gender neutral language does not mean we're excluding anybody.
Right.
What do you say about that?
Oh, 100%. It's including other people, you know, including terms for using reproductive health care instead of women's health care, pregnant patients instead of pregnant women. It's not taking away from the fact that you're a woman. That's insane. I identify as a woman. Someone saying that I'm a pregnant patient instead of a pregnant woman doesn't mean I'm less of who I am. It actually makes it better because I get to include more people into my identity. And it makes, I feel like my identity that much more special. There's plenty of room for all of us where we need to be. There's no need to be exclusive of one another.
Yeah, and I think that's probably the biggest critique I get is that we're trying to erase women. And that's not what we're doing at all. No. You know, saying, and I love when people comment behind those who are negative about that and say, well, are you not a person? If I use the term pregnant person,
right?
Well, are you not a person? Well, of course you're a person.
Right.
So this is not taking away from anyone. It is being inclusive of everyone, which I think we need to do. And especially in a field, which is traditionally called women's healthcare, you know, we have to start acknowledging that it's not just proper women's healthcare anymore. And we have to make efforts to include everyone because, and we'll talk about this in a little bit, the lack of doing so is going to affect the healthcare delivery to those who don't identify as women, whether we recognize it or not. And
Right.
we'll discuss more about that. But what I wanted to start off first is just by some simple terminology.
Mm-hmm.
You know, again, I want to preface this, but I am still learning. And I want to have these conversations because there's more that I can learn. And I also think that people who are listening, they want to learn as well. So starting first with just the basics of the vocabulary. First, what does binary mean?
So binary means there's only two options of
Mm-hmm.
one or the other.
Mm-hmm.
It's typically referred to of, everything from technologically like binary code of ones
Mm-hmm.
and zeros that are far beyond my comprehension,
Mm-hmm.
to referring to things like sex and gender, which we know is not the case anymore, but it's just essentially one or the other. There's no space for anything in between.
Yeah, and so we're basically in a very binary society.
Right.
Male, female, masculine, feminine.
Mm-hmm.
That's how we see or we put people into those two different categories. And we know now that it's not this just, we have known that we need to acknowledge and appreciate more that it's not just a binary society. And these are some of the first steps is understanding this terminology. The next thing is what sex is. Right. And I wrote everything down because I want to make sure I get it right, but I'll take this one. Sex is a term which refers to the person's chromosomal constitution, anatomy, whether external or internal anatomy, or a combination of the above. So typically it's referred to as what is assigned at birth. And most often when a child is born, they're assigned to what their external genitalia would be as the sex either being male or female. Right. And that's, did I miss anything on the sex definition? That's pretty simple.
Yeah, that's pretty standard. It's just important to know that there's lots of definitions to what someone's sex is going to be. You can go from genetic sex, external sex, internal, hormone profile. That's far from binary as well. Right.
And then sex assigned at birth. That is just as sex given to a person, and it's going to be whatever medical person first puts it on the chart, I guess.
Yep.
For us, it starts from right in the delivery room.
Right.
We have tags that go anywhere from the wrist to the chart, everywhere, and it has male, and you either put FE in front or you leave it as male. So that's generally, they're going to be assigned very binary as male or female, and that's what's going to be assigned at birth. And then what is a gender? What's the difference between sex and gender?
So gender is someone's innate sense of self as female, male, or none of the above. And while certainly most times it does tend to conflate with sex assigned at birth and other sexual characteristics that someone develops, they are actually two different processes that someone goes through. So sex assigned at birth and gender can be discordant from one another.
Discordant, right. And then gender identity. How is that different? Because we're going to build on the different from gender to gender identity. What is that? How is that defined?
Gender is kind of the umbrella term, just like kind of sex is the umbrella term, right? Sex can be defined by a lot of different things, and someone's gender can be identified by a lot of things. So someone's gender identity is how they identify internally as their gender. And then that can differ from gender expression, which is how they perform externally from their gender as well.
Okay. And then cisgender.
So someone who is cisgender has a gender identity that coincides with what their presumed sex assigned at birth was.
So it's what's the right word? It is consistent with, so this, whatever your gender identity is consistent with what your external genitalia would be.
Right.
Right. Okay. And then transgender.
So that would be someone whose gender identity differs from what their sex assigned at birth or external genitalia may be.
And it is appropriate to refer to someone as trans. That's not considered derogatory, right?
Everyone has their own individual preferences. So I certainly would check with someone, especially if you yourself are not identifying as someone who's transgender, non-binary, or non-conforming. Generally, yes, it's considered an acceptable term in a lot of groups, but I would always check in with someone else if you yourself do not identify as part of that group.
Right. So if there's a question, ask. Just to make sure, right? Because it's the safest thing. And then for a transgender man, you sent me tons of really good resources that I will share after this. But the terminology could also be female to male or FTM.
So from a medical standpoint, that's been used.
Okay.
It's generally, both from a science and just social construct, not the most appropriate thing because they weren't necessarily always female, right? That wasn't their innate sense of self. But yes, from an external genitalia standpoint, it would be female to male.
So is that, you're saying that's mostly in medical terms? Is that something that might be used in a medical chart or something?
You may see sometimes it in medical charts. It used to, I think it's definitely going out the window nowadays. I think most of the time in medical charts, we would see the term assigned female or assigned male at birth.
Got you. So that would be assigned female at birth for a transgender man, and then assigned male at birth for a transgender woman. Right. Okay. So just real quickly to the definition of a transgender man and transgender woman.
So a transgender man is someone who is assigned female at birth but identifies as male, and a transgender woman is someone who is assigned male at birth and identifies as female.
And that does not require any kind of surgery or anything else or hormone replacement. That's just how they identify.
Right. That's their innate gender identity, regardless of their expression, any other hormonal or medical procedures they've undergone to conform to a certain ideal of how they would like to look.
Okay. And now these are the next two terms are the ones that I have the most trouble distinguishing the two. That would be gender non-binary and gender non-conforming. How are those different?
Again, it's going to depend on what group you're discussing. Some people like non-conforming, and some people just say they're non-binary. Both identify with a group of people who don't particularly either identify with typical male or female standards, or they just don't identify as man or woman to begin with. And so that's those are going to be kind of umbrella terms as well for someone who just doesn't feel like they fit that binary to begin with.
So would this be a situation where you would ask as well if that individual considers themselves gender non-binary versus gender non-conforming?
Yeah.
And each individual might have their preference, right?
Right. Exactly.
Gotcha. Okay. And then finally for terms, LGBTQIA, lesbian, gay, transgender, queer, intersex, asexual, and any others. The plus means anything else within a sexuality and or gender spectrum. So is that the proper acronym, if you will, it kind of includes all?
Yeah, so that's kind of the general group of LGBTQIA+. People also refer to them as gender and sexual minorities nowadays.
Okay. Gender and sexual minorities. Okay, I did not know that. And that could be interchanged?
Yeah.
Okay, gender and sexual minorities. Are there any terms, because I asked before about referring to someone as trans, are there any terms that we should avoid?
So terms that have usually been used in negative connotations before, like transsexual or transvestite, have really gone out the window nowadays because they used to be associated with a lot of harm to the trans and GNC communities. They used to be, like I said, really negative connotations and slurs, essentially. And so kind of like an R word for intellectual disability.
Yes.
Unless you identify as that part of that group, it's really not appropriate for you to be referring to someone as that.
Gotcha. Okay. Any other terms we should avoid just to make sure? Anything else? Training. Gotcha.
You know, there's lots of other.
I'm sure there's lots of other slang.
Stick with that sort of stuff.
So anything that you might even think might be derogatory, just don't say it to be on the safe side. And you could always ask, I have individuals in my family where I'm learning from them as well. And I will text or ask what does this mean? How to refer to that? And I think that you have to be comfortable asking those questions, and there's nothing wrong with it. And that's the only way we're going to learn. Would you agree with that too? It's okay to ask.
Yeah. I think, it's definitely okay to ask. I think it's also important to recognize, though, that, in our learning, it shouldn't be put on a burden of someone who is identifying as a gender or sexual minority. It certainly applies to racial minorities as well in greater discussions of JEDI. And so I think it's important to just not assume. And I usually find what's helpful is just following the language that person
is using
themselves.
Yeah, that's a very good tip. Yeah, you kind of follow their lead, if you will.
Right.
Right. Okay. So let's go more into transgender, gender nonconforming healthcare. Why does it matter? And I get this. Why does it matter? I get that question a lot on social media. I know that it matters. Tell us why it matters.
at its core, we're healthcare providers and they're people who seek out healthcare. So we need to know how to best take care of them. And based on their social experiences and stigmatization in the healthcare community and just society in general, they're going to have very different needs than we're used to meeting with other patients. It's estimated that as many as 1% of all population in the United States identifies as transgender and gender nonconforming. And that number is actually a lot higher in youths than older adults. A lot of that, I think, just has to do with society being more accepting of differing gender identities. But that population is only growing. And just like any other population, they're going to have unique needs that we're going to be able or that we have to meet. And so it's incredibly important for us to make sure that we can be competent in healthcare for all of our patients and doing the work to make sure of that if we have a lived experience different from theirs.
And I think anytime you have a healthcare provider that's making an effort to get to know you and respect you, whatever that might look like,
right,
that only solidifies that physician-patient relationship and allows that person to reveal more about themselves, be more comfortable asking questions, be more comfortable telling them what's wrong if they're having certain symptoms that they might, it opens up that door and it can only help that physician-patient relationship rather than harm it. So, but that just goes for any time you're being respectful of an individual who's sitting across from you as your patient. We have to look at the whole person and realize what their needs are. And this is just one of the ways that we have to realize what their needs are, right?
Right. And, it's also recognizing historically what their relationship has been with the healthcare community.
Sure.
I think a lot of my trainings, some people have commented well, we don't need this because I'm going to treat every patient the same. You're not. You should not treat every patient the same. Every patient has very different needs. A lot of surveys of both trans patients and then healthcare providers have shown that people are really ignorant as to, one, how to care for these patients, and two, just how to speak to some of these patients, asking inappropriate questions that have nothing to do with their immediate healthcare needs, making assumptions, outrightly refusing to care for them based on their own prejudices. And so it's not like they're treated like every other patient who is cisgender or at least appears outwardly to match their sex assigned at birth. We very much do not treat them with the care and respect that they deserve. And this is why we need to do the work.
Yeah, and this is where it starts, by having these conversations. So again, I really appreciate you doing this because this is really going to help anybody that's watching this and those that will watch after. And you did mention that some of the stats, what I think is very, very important. And I think you said 1.5 to 3 million adults in the U.S. identify as transgender. I got different stats depending on where the resource was from. But then one of the things that you sent me to review, this I found interesting, this statement here. The stigma experienced by those who identify as transgender and gender nonconforming is different from those who identify as gay, lesbian, or bisexual.
Right.
Why is that?
So I think while that umbrella term of LGBTQIA+ or gender and sexual minority groups is helpful, they really do have two very different lived experiences, whether you're part of a gender minority group or a sexual minority group. Both have experienced very real, very hurtful stigmas, both in healthcare and in society. However, we see much higher rates of mental health concerns, particularly severe depression and anxiety. And those who are of a gender minority group, we see much more aggressive outward signs of violence and, sorry, I was getting a call. Outward signs of violence and stigmatization of those who are transgender and gender nonconforming, because it's more of a physical presentation than most sexual minority identifications are. And so just the data is astounding as to how much more violence people who are transgender and gender nonconforming, particularly transgender and those who are gender nonconforming of color, experience in general.
Yeah. And then you also sent me some stats. I'm just going to run through some of these stats that you kind of touched on. I've already mentioned this, that the healthcare system, by and large, does not meet the needs of the transgender community, starting from just how we even speak and interact with these individuals and these persons. That's just at the very basics. And then clearly we'll go on beyond that. And then something that you sent me was in 2012, there was a needs assessment by Washington, D.C. Trans Coalition, where they found 44% of those who were identified as trans identified health as one of their top priorities. And they said that access to transgender sensitive healthcare was their most significant need.
Right.
So does that mean that they don't have access to healthcare in general, or does that mean they don't have access to healthcare that is specific to them, or both? Does that make sense?
So it may be both.
Yeah.
I think in general, much like we know for communities of color,
Yes.
that they have been poorly mistreated in the healthcare system. And so unless they know a provider has done the work and been able to competently care for them, and they feel like they're not going to be asked inappropriate questions, turned away at the door, have those snide comments behind their back, they're really not going to feel safe going through a healthcare provider they don't know. And so that means they're not getting the same level of care as we typically would have, doing our routine annual exams, going to see a specialist that we've never met before. Yes, we may have some trepidations about that, but certainly not to the level of triggering your severe depression or anxiety associated with your gender identity. And so it's really about not having access to a provider who they feel like can actually care for them appropriately, let alone care for them to begin with.
Well, along the same lines, another stat that you sent me was that almost 20% of respondents in another survey had been refused medical care outright because of bias. I mean, I can never imagine someone saying, I'm not going to see you because your hair's red or your eyes are blue. I've never had to, I mean, and I know that's being very superficial, but that's what's happening. And so how, as a provider, and this goes along with biases of all types. And even when we speak of racism, we all like to think we don't have biases. Listen, we all do. The first step to changing anything is recognizing where that lies. But if you're an individual who does not feel they want to treat a transgender or a gender nonconforming individual, I do feel it is your responsibility to find them someone who can.
100%.
You don't have to. I mean, obviously don't if you're not going to like it or you're not going to give them care. Don't do it. But you know what? You should have resources available to them. You know, I refer you to this person. I do think that's on physicians in general and any kind of healthcare provider. If you are not able to or don't want to take care of a specific population of individuals, you should have the resources to refer them to someone who can. Would you agree with that?
100%.
Yeah. And we need to do that. I mean, you know, obviously don't do it if you're going to not be a good physician for that person, but find them someone who's going to do right by them. And we have to be willing to do that. Okay. And then what was the other thing? It was those identifying as transgender, gender nonconforming, were more likely to experience just adverse experiences in general. And we did touch on that. Then those who identify as lesbian, gay, or bisexual. I think it's for some of the same reasons that you mentioned earlier, just in the differences in the outward appearance that these individuals and how people are interpreting that. Is that right?
Yeah.
Yeah. Okay. Now, one of the other things I wanted to touch on, and you mentioned this at the top a little bit, some of the different types of stigma. And when I got this list, I understand. I mean, I never thought about these things because I guess I haven't had too much, but now it makes sense. And we'll go through some of this list. Stigma could range from having to actively teach a provider about their gender identity and what they need from them. And that goes along with what you said. You said to me earlier, it shouldn't be on the patient, right? So how could that be improved upon as a provider? What can we do to improve that? To take that away from that responsibility away from them. So, yeah.
I think it starts with our education as providers, whether it's medical school, genetic counseling training programs, nursing school. There are 10 million different jobs you can have in healthcare nowadays. Part of our education just needs to be stripped from that binary. And it doesn't have to be one particular lecture on this is what trans healthcare means. We need to stop referring to everything as strictly male or female and just talk about patients, just talk about reproductive organs, just talk about hormones, and recognizing that sex assigned at birth, both primary and secondary sex characteristics, hormone levels, genetic conditions, chromosomes, and gender identity and gender expression are all very different concepts that are separate from one another. Yes, they coincide a lot of the times, but when they don't, it does not take away from that patient's experience. And so it's not so much as just using a patient example when talking about an endocrine lecture, right? Because trans patients need far more than just endocrine care. They break their legs. They need to go to the ER. That ER physician and the nurses around them need to be able to properly care for that patient. But to care for a broken leg, it does not matter what surgeries they've had done to affirm their gender identity. It does not matter what groups they're a part of. If they've seen a psychiatrist, you're caring for them for a broken leg. And so it's not on you to be passing those judgments. That's for their care team, specifically for their gender affirming care.
Right. And so, I think, well, I was going to say, we don't get training. And I know I never did. Maybe hopefully now some of those that are in medical school and different types of medical field training are getting exposed to this more than I did. But I've had to learn on my own. Just when learning about health disparities and racism in medicine, another topic that I'm interested in, I've had to make the effort to learn about that. So, sometimes we have to go beyond what our curriculum is and our training in order to get extra training ourselves in order to be a better physician. And this is just another area where we might have to do it on our own, right? I'm sure that is that what you did? Did you do this on your own? Yeah,
pretty much. It started from me recognizing a couple of differences in just how we create what we call a pedigree here in genetics, is how we take the family history and symbol representation of people. And we didn't have symbols for those of gender minority groups, which is a big barrier to care in genetics because the pedigree rules everything in genetics.
Of course.
And so it kind of started from there, and we don't have a ton of scientific research on how to best care for trans and GNC communities. And so I actually had to turn to sociological studies and finding some of those out. So opening up to a whole new world of information. But, we expect ourselves to have continuing education for the science part of our job. But we also need to include in that continuing education the people part of our job. And this is part of that.
Yes, exactly. And there actually are resources out there, and just like the ones that you sent me, where we can get that education on our own. Along some of the other lines that we were talking about, the different types of stigma that these individuals can experience, and you mentioned this as well, being asked invasive questions about genitalia that have nothing to do with the reason why they're there, or experiencing genital exams when there's no indication to do so. That happens. I'm sure that, just like you said, if they go in for a broken leg, are some of these other things necessary, right? Right,
exactly.
Being refused treatment, we talked about that. Being recommended to attend conversion therapy, which is legal in Pennsylvania. That's definitely a stigma for there. And is that the only state in the country that does that?
No. There are many states where it's still legal. Actually, most states it's still legal.
Still legal, okay. Those identifying as trans or GNC are less likely to have health insurance or attend routine well checks, which we talked about. And then you also mentioned this about mental health. Up to 40% of trans identifying individuals have considered suicide, which is, it's alarming.
Yeah.
It's alarming.
Much higher than the general population. It's much higher than those of sexual minority groups, even though it's still elevated in those of sexual minority groups. That's almost half of that population, almost 0.5% of the population in the United States. That's insanely high. And so I think knowing that number and knowing how alarming that is huge, because some studies have also shown that just one person affirming their identity is enough to significantly reduce that rate by half. And that one person does not have to be a personal close friend or relative. It can be their healthcare provider. And in healthcare, essentially, we're here to save lives. That's the core of why we're here, right? And so if this helps save a life, why wouldn't you do this work? That's to the core of being a doctor. That's to the core of working in any field in healthcare.
Yeah, when you said, I read that, and I was kind of blown away. It just takes one person, and you might be that one person and not even realize it. So if that one person can make a change or a difference in someone's life, then just be that person. And it could be something as simple as asking what their pronouns are, validating them, identifying, trying to establish a rapport and a relationship in any small way can really make a change in that person's life. And we're going to talk about that next. Things that we can do. And you had this really cool handout. Where did that handout go? That I'm going to use, that you sent that to me. But we're going to start from the top. So ensuring equitable care for trans and GNC patients. And I'll put this in the resources as well. We already went over the different terms. What are some of the different things that we can do as far as departmental changes? And this again is on the list. And then some of the discussion tips and how we're having a conversation with a trans or a GNC person. Let's start first with some of the things we could do within our own department. Yeah.
So I think at first it's getting rid of some of that binary language and working with some other members of your department who are having difficulties with that. I think on intake forms, it's asking about gender identity specifically and how that may differ from sex assigned at birth, asking about pronouns from the beginning on your intake forms, and not leaving it as a choice for patients, but essentially just leaving a blank. So when it says gender identity, just leave a blank there. Don't make someone
click a box,
identify it for themselves, right? Same with pronouns, allowing that open spot there. And it then allows them to leave it open and blank if they don't feel like they want to disclose or share any of that information. But it also gives them the opportunity to say, hey, they've actually thought about including some of these things. Maybe someone's done the work here. Maybe this is an okay space for me to be in. And so, you know, from just a purely systemic view, that's something easily that departments can change. Ask your department heads and some of the higher ups of some of those questions of, are there some of these barriers? Can we perform ultrasounds on someone who's listed as a male? If that's not the case, that needs to change. Can we have some of these kind of institutional policies reviewed through EPIC or whatever EMR that hospital uses, through the OB ultrasound system that it uses? So start thinking about what some of those barriers to care may be that we may not have thought about before. And as a cisgender straight woman, I hadn't thought about it until unfortunately we had that experience with that patient. And so hopefully these kind of resources help trigger some of those conversations in your brain of, you know, what about my practice is inherently not equitable for patients who may identify differently than most of my patient population.
And that, I mean, that's just the tip of the iceberg. I'm sure there's so many things that are inherently in our system that we don't even realize that are roadblocks. And sometimes it just takes just going through it to realize where they are. And like you said, you had that situation with your patient, and that kind of opened up a whole box of things, if you will, that needed to be changed. But was it hard to change it?
So it really wasn't that difficult. I think it was just a matter of no one had pointed it out before, right? No one made the effort to say, hey, this is a problem, instead of, oh, this was a one-off, it probably won't be a problem anymore. Like, no, this just needs to change for everybody. That's good to know, because it probably isn't. My guess is it's probably not that hard to change. No, it's not. There's modules in EPIC to include pronouns. There's modules in EPIC to include preferred names. Even if there aren't those things, your personal introduction to a patient is very easy to change.
So let's talk about that. Some of the ways to that first interaction. What are some of the things we can do with that initial interaction, with that first visit?
So a lot of times my first interaction is I ask for their name that's listed on their chart, confirm their date of birth, and say, hi, my name is Liz. I'm your genetic counselor today. My pronouns are she, her, and we're going to talk about findings on ultrasound, hopefully answer a few questions for you. You know, I have here that your name is listed as this. Is there another name you'd prefer to go by today in our conversation? That's it. It's as simple as that. I know my full name is Elizabeth. I'm only use that when I'm in trouble with my mother. So if someone asked me and said, you know, is there another name other than Elizabeth you'd like to go by? Yeah, I'd probably feel a lot more comfortable if they said Liz. And that automatically puts me a little more at ease with my provider.
And then there's other thing that you sent me also said, if you're a practitioner or provider who's had limited experience working with the transgender GNC community, if that's the case, one of the things that they said was, please correct me if I make a mistake. I want to get it right. Do you think that's appropriate? Is that something to, I mean, for me, I don't want to walk in and assume that I'm going to get it right and then make an overt mistake. So what can we say?
So I think if you do make a mistake and a patient points it out, you just apologize, say the correct thing, and move on.
Yes.
I don't know that you want to outwardly make an assumption that you're going
to make a mistake. Gotcha.
Because you're the expert in the room, right? That's why the person came to see you, for your expertise. And I don't know that it really sets up the good expectation that you are going to definitely make a mistake with them. And that's automatically going to be going through your mind throughout that whole consult with them. And so I think it's just a matter of, you know, use whatever information you have to begin with, and including that on intake forms or at least the sheets that schedulers use to schedule patients is a helpful kind of first tip for you. But to automatically, and that's where kind of some of the language changes comes in that you shouldn't make mistakes if we're not making assumptions.
Yes. Yeah. And then one of the things that also is about the partner, and, you know, referring to someone in the room with them as a partner is not bad, because sometimes people aren't married. Sometimes
most of our patients are not married.
Or they're not married. And so a partner is safe. And I was doing that before I even tried to be more inclusive in my language, just because I made the mistake of calling someone grandpa, and it was not the grandpa. And I felt really, it was the partner. And, you know, it made me feel really bad. So I thought, you know what, this is just my word I'm going to use just to be on the safe side. So, you know, again, this goes to show you some of the terms that we're using that are being inclusive. It's not just because it can be even more widespread than being, you know, more inclusive of the transgender and GNC community. It can be more inclusive even beyond that. So, you know, it's the partner. Once I've made that mistake a few times, it just became easier to use the word partner. So let's get into the whole the language. You gave some examples of how to change language, and, you know, when I started, and it really I got challenged when I was writing this paper, because it's a paper about quote unquote women's health, pregnancy. And I'm like, how are you going to avoid saying women or female? And I'll be honest with you, it was not hard. It was not hard. Yeah. And I was really surprised at how not hard it was. So it's basically just, for me, getting out of the habit of it. Right? Of habit of saying women's health care or male or female pregnant woman. It's out of the habit, because the terms that I've substituted make perfect sense. So it's not like people are going to look at it, unless you really pay attention, you're not going to realize really that I'm even doing that. Even if you're reading the paper. So talk about some of the ways that we could change our language to make it more inclusive, even just down to talking about ovaries, uterus, tubes, and ovaries.
Yeah. So I think baseline is pregnant patients or pregnant person, just to kind of take the gendered aspect out of it. Like we said earlier, a woman is both a patient and a person, so we're not taking away anything from a woman for saying that. It's still going to be your own healthcare. Your provider's there to take care of you. You know, using terms like egg and sperm at a more biological sense, or parents instead of just mom and dad. Like you said, referring to a partner and using the term partner, or a more vague they for anyone referring to in the family history, unless they themselves kind of present a pronoun for that person or for themselves. Using like reproductive organs like uterus, ovaries, or testes, penis, instead of just male and female reproductive organs. You have the X amount of organs if that's necessary for you to have your conversation with the patient. Estrogen, testosterone. So we don't have to assign them male or female, especially in healthcare. It's our job to be able to explain these things without just saying man and woman. We should know what they are to their core, and if we can't explain them, we're not doing a very good job at our job.
Yeah, so that's just a few of the words. And then what was it? We had, let's see this list that you had. Yeah, you talked about use the proper terminology, which I think would be, like you said, even easier in medicine, because we have the proper medical terminology that by and large isn't necessarily binary, if you will, because we're using the proper terms. So, you know, and I found that also when I'm counseling patients, especially on ultrasound findings and that, it's not necessary to identify even the fetus as being male or female if you're when you're counseling on certain things. So, and that's just an example. I've actually found myself doing that and not having to use, when I thought about it, that I would never even use the term male or female, because I was just using the medical terms. So, you know, it can be done. It's going to take some effort. It's going to get you out of the habit. of saying things that are traditionally, especially in women's healthcare, and I'm sure you would agree. But the benefit of it is so much more than any work that you have to do to put into it. Does that make sense?
Yeah, exactly. And even, so this was a big conversation that we had worked on and studied with in genetics, because obviously genetic sex does have a pretty big implication for some conditions that can be passed along an X chromosome. So most women have 2 X chromosomes, most men have an X and a Y, and how you present that to a patient is important, right? I think distinguishing sex and gender is incredibly important. If I have to hear one more time about the gender test, I think I'm going to scream. Because it's not even the point of that test, but it's, part of that is just part of our education, both in and out of the office of, this gives us likely fetal sex based on X and Y material seen in blood, or, most likely a boy based on the fact that I see a penis on ultrasound, most likely a girl because I don't see one on ultrasound. But part of that is just, not falling into the trap of easy language and really sticking to what are we actually saying from a science standpoint, and explaining that to a patient of, this is what science tells us is happening right now. That I think it's a very, very good summary of that. So I hope that this kind of encourages some people who are going to watch this now and later to try it. Just try it and see. I think for me, it was much easier for me to make the effort by when I'm writing stuff out because I had to think about it. I still mess up more when I'm speaking. Because if you speak fast, you forget about it. But, I start with writing, and when anything that I put on paper, I always try to change it and make it more neutral, just in day-to-day stuff, actually. So, and then that kind of translates and makes it easier when I'm at my job. So that's how I personally am, handling this and changing things for myself. And I find that that's working for me. Do you have, other than, obviously doing the education on yourself, on your own, do you have any other tips to help healthcare providers to start that process of becoming more inclusive? And I think just keep practicing to yourself. So, it's something we say to all our students in their clinical rotations all the time of, it sounds stupid, but looking at yourself in the mirror and talking about something of describing, aneuploidy screening options of NIPT versus CVS versus amniocentesis. If you don't feel comfortable in that, just practice, right? Something that some of my coworkers have done are putting little Post-it notes of patient, person, so just a conscious reminder there saying, okay, this is a word that's good for me to use. And it truly does. I mean, I don't even give it a second thought anymore in the couple of years that I've been working on this. And, I was fortunate enough to grow up in a pretty progressive household with exposure to those who are gender and sexual minorities, even though I myself do not identify as one. And so, I certainly can understand with people who haven't had that exposure before, both professionally and or personally, it may be a longer process for them, but it's well worth it to put in the work, because the moment that you see a patient, when they realize you have, they can trust, is just worth all of it to begin with. Like, this is why you're there, to do your job as a healthcare provider. Okay, so let's go through and see if there's any questions. Someone had asked about intersex, which I actually think is important to talk about.
Let me find that. I that's where I was going to go, actually. It's down here.
I'm a butcher.
There it is.
Intersex is certainly under that gender and sexual minority spectrum. However, it's not so much necessarily indicative of gender identity. So for someone who's intersex, it usually has to do with sex assigned at birth. And either it is ambiguous genitalia, so either genitalia that doesn't look outwardly male or female as we would expect it to be in the beginning, or there's female genitalia that's maybe a little different, so clitoromegaly, or the clitoris is a little larger than it would be expected, or hypospadias, where the penis isn't as large or maybe as differentiated as we would expect. And those who are intersex can have genetic conditions that cause them to be so. So even if they have pretty clear male, female identifying external genitalia, but maybe their hormone profiles aren't consistent with that. Or if they run what's called a karyotype, which is a picture of all of our chromosomes, and it's different from what their sex assigned at birth is. There may be a genetic cause that have caused that to happen. Now, that doesn't necessarily mean that someone's transgender or gender nonconforming. Their gender identity is going to be completely separate from that, though they are going to experience some of those concerns that we've talked about today that those of the trans and GNC communities can face. A lot of institutions have banned intersex surgeries after birth nowadays, allowing that individual to be cared for as they're born, allowing them to figure out the gender and sexual identities as they get older. Which thank goodness that's happening, because we're essentially choosing someone's path for them based on what we presume their genetic sex is going to be, based on external genitalia and or genetic test results, which really has been shown to be really harmful to people. So they are very different concepts, but yes, a lot of people who are intersex experience some of these big stigmas that we've talked about today.
Yeah, that was a really good question. And so anyway, I think that's all that I had on my list. Can you think of, is there anything else that you would add that you think might help, or as healthcare providers, even as individuals, to help be more inclusive in general?
There's lots of things that I think, like you said, putting in the work, but I think part of it is just, keep diversifying who we follow on social media to get different human experiences. There are wonderful transgender, non-binary, non-conforming individuals on Twitter, on Instagram. Jeffrey Marsh, Alak, I can't remember their last name. I can send you a couple and post some of their bios on here. But they're just people who are willing to share their life experiences, are incredibly brave to do so, challenging gender and sexual binary identities, and just exposing yourself to just more human experiences can never hurt. I think, like you said, we're all going to have our biases because we only live one specific timeline, right? And an infinite loop of different timelines that we have on Earth here. And so, just giving yourself more, even just outside of a clinical spectrum of what other people go through, is always going to make you a better provider.
Yeah, I mean, I think anytime, and I mentioned this before, I really, for me as an individual, and I've kind of always been like this, I really like to sit down and talk to my patients. I want to know more about them. And I try, even if I don't have time, I try to make time at some point. And you'd be surprised at what you learn about people and how much it changes when you really make that effort. And it doesn't have to be a 20-minute conversation. It could be a 5-minute conversation. And just the fact that you sat down and looked at them face to face instead of standing over them, and, and just having that conversation to find out more about them, it changes everything for that patient. And they view you in a different light as someone who cares and wants to get to know them, no matter what aspect that might be. So we just have to make the effort. I mean, we are in medicine. We are healthcare providers. It is our job to take care of people.
Right.
No matter what they look like, how they present themselves, it's our job. And again, I do want to say, if you find yourself as someone who can't or won't, for whatever reason, please have resources available to refer anyone to someone who can take care of them for them properly.
Right. And there's really, at this point, there's no, someone in genetics, someone in obstetrics and gynecology can make these changes, things that are very historically binary. You can apply these changes to any practice.
Absolutely. Absolutely. It just takes that one person.
Right. Exactly.
One person. Well, thank you so much. Well, I do have a question. You are on Instagram at A Girl's Name is BizBiz.
Yes.
Is that from Game of Thrones?
Game of Thrones, yes.
I knew it. I
was late to the Instagram game. And so my handle for everything on socials or everything has always been BizBiz93.
Yeah.
And so someone had already taken it by the time I got to Instagram. No. I don't know who they are. But so I that had just happened on Game of Thrones a couple of years ago. And so I took it for that. So I'm not super active on Instagram as far as, you know, genetics, healthcare. I do share some resources, but on Twitter, actually,
Twitter, tell me Twitter.
I am very active with kind of the intersection of genetics, social justice, and how they kind of all come together. And so they can find me on there too if they're looking. And I usually share other providers as well who do that.
Yeah, and I will include that in the caption on this video. And by the way, the reason why I noticed that is because I'm actually rewatching Game of Thrones as we speak. I just finished season 2. I watched it already, but I was like, you know what? I'm going to watch it again. I feel like I never watched it.
That's an undertaking. That's a long
It is. Well, I have an hour drive to and from work every day, so I can knock out an episode easily.
Oh, there you go. Perfect.
and the sound in my car is so good. It's like I'm in a movie theater. So.
Oh my God, that's amazing.
Okay. Well, thank you so much, Liz. I really appreciate your time. If anybody has any questions, you can DM me or go to Twitter and BizBiz93. You can find Liz Sheehan and see who she follows.
Yeah.
That's what I'm going to do. I'm not that big on Twitter. I just reopened a new account, so I'm going to go find you right now.
All right. Sounds good.
Thank you.
All right. Bye, guys.
Bye.